Hello and welcome to Season 2, Episode 25 of the Physician Assistant Exam Review Podcast. Today's going to be all about welcome back and let the murmurs begin. We'll be covering beginning to cover valve disorders and murmurs and heading from there. All right, well, so much news to share with you today. This is another restart of the podcast. I quit on episode 24 back in a long time ago. Those of you who are listening for the first time and straight through, I apologize. I'm going to spend a little bit of time here filling in the loyal listeners who have been with me for a long time and giving a little bit of information about what's going on with me, the Physician Assistant Exam Review, the site, everything that's happened over there and here, and just spend a little bit of time recapping some things because there's been a ton of new developments. And I stopped the podcast. I had been doing tons of them. In fact, I got to the point where I was thinking about going from a bi-weekly show to a weekly show. Things were going so good. I had a really good system down for producing them that I was speeding up. And then a baseball season hit, and I wound up coaching 3 different baseball teams, 2 in-house teams and a travel team, and head coaching one of them. And it just became so much that I couldn't quite handle that. Also, at that time, I started down a little bit different path with Physician Assistant Exam Review. And what I mean by that is I started spending a lot more time with the email list, with the people who signed up for the emails. I used to only send out about 1 or 2 emails every month or so, very infrequently, a little bit of information. Sometimes if I had something new coming out or a new podcast episode, or if I was redoing something, a new product or something that I thought you might be interested in, I'd send that out. Well, back around the same time as baseball season hit, I came across this idea of sending out regular emails, daily emails that would cover the things that, 1, I'm most interested in, and 2, the things I think that are most valuable for you. That being said, so that's the over at the in the email list, what I've been doing is writing a daily email every day, cataloging study tips, things I think will help you be prepared, things that'll help you on rotations, advice I have now that I've been working with more and more students on rotations, advice I have for students, advice I have for getting your first job or another job or a better job, interviewing skills, all this stuff I've been putting out constantly through the email list. And it's been great. I've been getting so much good feedback. I've really been enjoying it. It's been a ton of fun for those people who are involved over there. Now, I understand historically, perhaps some people don't sign up for the email list, for whatever reasons. I go to tons of sites and I don't sign up for their email lists. Sometimes I want what they're offering me and sometimes I don't. But I've decided to go a whole different route with the email and really spend a lot more time in there. So I've spent the last year developing the content there and going through and just covering a lot more of the hows and whys and less of the content of the exam, but more the how your brain works kind of stuff, how to memorize things, better ways of attacking certain material, that kind of stuff, which I think is incredibly valuable, far more valuable than the content itself. The content is helpful, but that other stuff makes it so that you can learn the content, that you can pass your exam, that you can see patients confidently. To me, the content is easy in comparison to that stuff. So like I said, I go into a ton more of that stuff in the emails now that I have it set up that way. Let's see. What else did I want to talk about with you guys today? Well, maybe that's it. Maybe I'll think of some other things as we go. So anyway, if you want to go ahead and sign up for the emails, there's a couple ways to do it, and I strongly recommend that you do that. You're going to just get so much value out of it. You can head over to the website, physicianassistantexamreview.com, and there'll be obvious ways there you can sign up for it. Or as of this recording, where is it? It's someplace in here. You can text PA exam, just the letters PA, and then the word exam, all one word though, don't put any spaces in it, to the number 33444. That's 33444. So 2 3s and 3 4s. So it's a little confusing. Text the word, all one word, PA exam. And as of this recording, I had it set up so that you'll get the cardiology chapter of the final step delivered directly to you when you send in that when you text that to that number and send in your email address, and that'll get you onto the email list. And again, more importantly, some of it is cool. I mean, the cardiology section is totally worth it, even if you just do that and then unsubscribe. There's a brilliantly designed unsubscribe button right at the bottom of every email, so it's super easy just to hop in, get that PDF, and get out of there if that's all you want. But I can't recommend enough. It's really been the thing I've been having the most fun with. I think it's been helping the most is all the information coming out through the email list. Like I said, through those daily emails that I think you will get a ton out of. So my strong recommendation is you head over there to the website, or again, just text to the number 33444 PA exam. All right. So with all of that said, I'm planning on picking back up with the show. So let's just pick right up where we left off. So for those of you who have not been longtime listeners, and you're just listening now for the first time, you don't even barely notice a gap between episodes 24 and 25. But it's about 8 months, 9 months between those two episodes, or that last episode and this episode. Hopefully it will be quite a bit shorter between this and the next episode. So let me move on from there, and let's jump into what was been one of the greatest feedback sources for what I'm calling season 2 are the priming questions. Priming questions get your brain focused in the right direction. I believe strongly in learning the easy stuff, making sure you've got all your facts down pat. That's what the final step the book is all about. And this is one way to get that started. And a way for you to retain information as you're moving forward is to make your brain work a little bit, to make you have to think, to make it not just sit and listen to the show, but actually participate in the show as you drive down the road, as you go for your jog, not just stare off into space and let it sink into your head, which is not, it's still somewhat useful, but far more useful is the idea of using your brain, thinking things through. So let's start with today's priming questions. Again, we're going to start off today. We're beginning murmurs and heart valve diseases. Where are the sounds from the pulmonary valve typically heard best? So on your physical exam, where are the sounds from the pulmonary valve typically heard best? Is aortic stenosis more common in men or women? Is aortic stenosis more commonly found in men or women? And then here's one I have to go back and look up every single time. Define paroxysmal nocturnal dyspnea. I do like saying dyspnea, though. Define paroxysmal nocturnal dyspnea. And again, I don't give those answers to the end. This is for you to, 1, think about now, and then 2, to concentrate a little bit as I go through today's material, looking for those answers and see if you can come up with them if you don't already know them. All right, so let's jump right in. When I say jump right in, we're going to start with heart valves. I really like foundational information. I think higher level stuff is super important. I think calculus, algorithms, logarithms, whatever you call them, all of this stuff is trigonometry, super important. I totally get the value in learning that information. I'm not putting it down. But my strong feeling is that if you don't know your multiplication tables, then all of that other stuff is 10 times as hard to learn. So I like to start at the very beginning and make sure that we have a strong base and that we understand things as we go, not just memorize lists. Memorizing lists is of pretty much no value to anyone. Gathering a strong understanding is extremely valuable because even if you forget something, you can relearn it super fast if you understand it and have your brain wrapped around the material. So we're going to start with heart valves. There are 4 heart valves. Hopefully at this stage of the game, you can name those 4 valves. I actually found a little more trouble when I went back to do this than I would like to admit. They are the aortic valve, the pulmonary valve, the mitral valve, and the tricuspid valve. The aortic valve. So I want you to think about the heart and how it functions and the anatomy of the heart. This sounds easy if you're in school, but if you've been in dermatology for 15 years, the anatomy of the heart, including the valves, gets a little tricky again all of a sudden. Blood flows from the left ventricle into the aorta, or out of the heart to the rest of the body through the aortic valve. The pulmonary valve, blood flows from the right ventricle into the pulmonary arteries and out to the lungs. So again, these are both oxygenated blood. Mitral valve, these are going to be the atrioventricular valves, the mitral valve and the tricuspid valve. Blood flows from the left atrium into the left ventricle. And then with the tricuspid valve, blood flows from the right atrium into the right ventricle. Right? Pretty straightforward stuff. Simple. Excellent. Another thing this does is by covering some relatively easy material, it gets your brain sort of warmed up. and gets you feeling a little more confident. Confidence is something else I talk a lot about. Is incredibly important in when it comes to one, learning material, and two, test taking. I can't overstate the importance of you being comfortable, you being confident that you know the material, and a strong understanding and some a strong grounding in some basic facts really goes a long way to providing a ton of confidence. So those are our uh, valves, and again, not starting off a little slow here. All right, so heart sounds. Let's talk a little bit about the different valves and their heart sounds. And how I'm going to go through this is I want to do the aortic valve, then the pulmonary valve, then the mitral, then the tricuspid. I just think it makes sense. We'll do oxygenated blood, then go down the line. So aortic valve heart sounds. This may be heard on the left or the right sternal borders, depending. We'll get to that in a little bit. It's in the second to fourth intercostal space, typically in that second intercostal space, but you can hear it between the second and fourth intercostal space. The pulmonary valves, the pulmonary valve you can hear in the left sternal border at the second intercostal space. The mitral valve, think for a minute if you can remember where you hear that one, the mitral valve. It's in the left midclavicular line at the fifth intercostal space. And the tricuspid valve, it's at the left sternal border in the fourth intercostal space. So basically, tricuspid valve is just below the pulmonary valve, left sternal border second, left sternal border fourth. The good news is, as we go through and we cover murmurs and we cover aortic valve issues, there's only really two problems that valves have, right? They can either be stenotic, so they're stiff and they don't open well, or they can be insufficient or not work right, so then you get regurgitation or backflow. So in one sense, with stenosis, a stenotic valve won't let as much blood out through it as it should. It narrows that opening, makes it harder for the heart to push blood out through the opening. And in an insufficient valve, once the pressure drops a little bit, that valve doesn't close all the way, and it allows some of the blood to leak back into the heart. So we'll start with aortic stenosis, and then we'll get into some stories when we hit aortic insufficiency. So at the aortic valve lies between the left ventricle of the heart and the aorta, which we talked about earlier. Therefore, it is a high-pressure system carrying oxygenated blood out of the body, right? So we're pushing from the left ventricle really hard out to the rest of the body. That's important to understand, and why we wind up with some of the symptoms and some of the things we get and some of the treatments, is understanding that the levels of pressure and what's going on here. For aortic stenosis, it is believed to be similar to atherosclerosis, and it's the most common valvular heart disease in the U.S. Causes a congenital bicuspid or unicuspid valve. Can be a cause. It's pretty rare. Symptoms of this usually occur not until middle age, so not when they're babies, but later on. Rheumatic fever is a possibility, obviously becoming less now. Most commonly is a degenerative or calcified aortic stenosis. Upwards of 25% of patients over 65 have some degree of aortic stenosis. Clinical presentation, people may come in for a routine medical exam. They might find that they have exertional dyspnea. So again, or syncope or angina or CHF. Think about these symptoms. If you're trying to pump blood out to the body and the left ventricle is having trouble pushing it through the aortic valve because it's stenotic, because it doesn't want to open all the way. So think about a door that's not quite, it opens enough to let some out, but not all the way to let everything out. So if you're exerting yourself, if you're exercising, well, the heart's going to try and beat a little bit harder, push a little bit more blood out, a little bit more oxygenated blood out to the body. If it can't do that, you're going to feel short of breath. So this is your exertional dyspnea. Secondary becomes your syncope, and on top of that as well is angina, because you get poor perfusion of the coronary arteries. So you may get some angina from an aortic stenosis. Physical exam findings. This is the part everyone wants to know about, the murmurs. A murmur for an aortic valve stenosis would be the right second interspace. It's a harsh crescendo, decrescendo, mid-systolic ejection murmur. So again, if you understand where the aortic valve lies, then it makes sense that it's a systolic ejection murmur, right? As the blood's being pushed out, the pressure's going up. That's where you get that harsh crescendo, decrescendo of an aortic valve stenosis. And this very commonly radiates to the right neck. In fact, a couple places I looked this up were saying that if you don't have radiation to the right neck, You should be second guessing the diagnosis of aortic stenosis because it's very specific to aortic stenosis. And you can hear this best with the patient sitting and leaning forward. Labs and studies, you're going to get an ECG, which is going to show or may show left ventricular hypertrophy. We'll stop and think about it. Why would it show left ventricular hypertrophy in this case? Well, if it's a greater pressure it needs to get through that valve and get out through that door, the left ventricle is going to have to work harder. It's going to have to push harder, in which case it's not going to, it's going to have to build up more. It's going to have to hypertrophy. It's going to have to build up more muscle in order to get enough blood out of the heart and into the rest of the body. Next, you get a chest X-ray, which may show a calcified aortic valve, and then an echo with a Doppler is going to be diagnostic, where you can actually see the blood flow through the valve, and they can measure the gradients and everything else. We're not going to get into that sort of detail here, but that would be the way to diagnose this. Treatments. Well, it depends on exactly what you're going to treat. You're going to use medications to treat angina and to lower blood pressure overall, if you need to, because they typically often go hand in hand. The person has high blood pressure, doesn't cause aortic stenosis, but they typically, someone who comes in with aortic stenosis is often going to have high blood pressure also. So for angina, you're going to use beta blockers and calcium channel blockers. I'm going to talk about a little bit more in a second, but you're going to want to avoid nitrates due to risk of severe hypotension. Actually, let me just jump into that now. It's generally recommended that you avoid arterial vasodilators in general in patients with left ventricular outflow obstruction. So when we say left ventricular outflow obstruction, right, that's just aortic stenosis or something blocking the flow out to the aorta. The left ventricle can't send stuff out. And the reason why you want to avoid a systemic vasodilator is because when you're trying to lower blood pressure and you put out a systemic vasodilator, you lower blood pressure dramatically, and it doesn't change the heart's ability to get blood out through the aorta. So let me see if I can clear this up in my own head so it can make sense for you. So what happens is that's not going to help the heart and how much blood it can put out. So when you drop the blood, the arterial pressures, when you drop the arterial, when you dilate the arteries, what happens is the blood can't get out to fill up that space. So you wind up with an extremely low blood pressure. In fact, it drops really, really big, as opposed to lowering the contractility of the heart, as opposed to something along that nature, which will help, which won't affect how the heart's pushing the blood out. Because remember, it can't get blood out through the aortic valve, no matter what's going on downstream, no matter what's going on systemically. So what happens is when you use an ACE or certain beta blockers or nitroglycerin, you get that severe arterial vasodilation, and the blood pressure doesn't just drop because the person can't compensate by increasing blood flow out from the heart, because that aortic stenosis, the systemic pressures really drop dramatically. I hope I didn't muddle that up too much on you, but so it's usually recommended to avoid anything that's going to cause a systemic arterial vasodilation in a patient with aortic stenosis. All right, let's see if I can make a little bit better out of the valve replacement part of this. So surgically, if the valve is just simply is too stenotic to be functioning, you can go ahead and have someone put in a prosthetic valve. This will last long, but requires anticoagulation. You can get a pericardial or porcine valves that do not require anticoagulation, but do have shorter lifespans and may need to be replaced. A Ross procedure is the replacement of an aortic valve with the patient's own pulmonary valve, and a cadaver valve replaces the pulmonary valve. So this may last a little bit longer. And then a balloon valvuloplasty. So they put a catheter in and blow up a balloon inside of the aortic valve to break off the calcifications and see if they can get it moving. This may or may not be effective depending on the patient and everything else going on with them. All right, so let's jump into aortic insufficiency or aortic regurgitation. So this is the leaky valve that allows the backflow of blood during diastole. Males more commonly have this about 3-to-1. So more often you're going to see males with aortic insufficiency. The story that struck me as I was thinking about this was years ago. It was probably the second house. My wife and I bought and sold too many houses when I was just getting out of school or into school. The first house we bought when I got out of school and I had a real job, and we bought a nice, 4-bedroom, 2-car garage house that we wound up finding out was a disaster and left. That's a whole different story. One of the first disasters we had with it was we were up on a hill, but somehow we were the lowest house on top of the hill. So our backyard would flood. And in addition to that, so we had a sump pump. And in addition to that, the previous owners had never, ever set up downspouts and gutters and things correctly. So all the water ran right along the side of the house. Well, I found out was it Christmas Eve? Either way, I just remember my in-laws were there, making it that much more interesting. And what happened was the valve from the sump pump that leads out to the house in that pipe broke. So what would happen was the sump pump would run and pump the water out of the hole in the basement. For those of you who don't have a sump pump, what happens where we live is the water table's usually pretty high. So if you have a basement, they dig a hole about a foot or two down, and you put a pump in the bottom of that hole. And if that hole gets water in it, the pump pumps the water out to the outside world, and then it's really usually not a big deal. As long as that pump is running and you have electricity, not a problem. Well, that pump in my house, the water would pump up, but it's about 10 feet right up out of the basement and then out into the pipe that leads outside. So it would pump, about 10 or 15 gallons of water out from that hole up through that pipe. And then there's a switch valve at the bottom of it. So as soon as the pressure would release from below, the valve would close, and it wouldn't allow the column of water that was inside that pipe to fall back into the hole. Well, that broke on me. So I had an insufficient valve or regurg in my valve from my sump pump out of the house. So what would happen is it would pump that 10 to 15 gallons up out of the hole in the sump hole, but then probably 3 or 4 gallons would rush right back in as soon as the pump turned off. So it would have to run twice as much and burn out the pump and cause all kinds of problems. So anyway, that's just one more example of a leaky valve that doesn't work. Causes for aortic insufficiency: aortic root dilation. So the root of the aorta gets widened out, and it makes that valve not seal as tight when it closes. 80% of these are idiopathic, meaning we don't have any idea why they happen. But aging and hypertension certainly play a role, and there are lots of other reasons. I'm not going to go into all of them here. Rheumatic fever is historically relevant, but now much less of an issue. A congenital bicuspid aortic valve is a possibility here. And then some other diseases that if a patient has one of these, one of the symptoms may be aortic insufficiency. So Marfan syndrome, Ehlers-Danlos, ankylosing spondylitis, systemic lupus, and syphilis. So things that are connective. So basically what you've got are connective tissue disorders or autoimmune disorders, and then syphilis can also cause an issue here. In the acute setting, so a patient comes in with acute aortic insufficiency, things to consider here are endocarditis or aortic dissection. Clinical presentation, this can be found in a routine medical exam, asymptomatic, usually until middle age. And again, exertional dyspnea, orthopnea, angina, paroxysmal nocturnal dyspnea, and palpitation. So again, think about what's going on. If so you've got systolic pressures go up, the valve opens, the blood rushes out. Diastolic pressures drop, and the pressure inside the heart drops relative to the arteries. Some of that blood flows back from the aorta into the left ventricle. If that happens, then there's less blood circulating through the body, right? So you can get exertional dyspnea, especially so as you begin to exercise and draw on more, or require more oxygen, you're trying to draw more blood in. And as the pressures go up in the arteries, then more of that blood is going to drop back into that left ventricle. Orthopnea makes sense similarly. Angina, same as we talked about before with aortic stenosis, and so on. Physical exam findings. The murmur here, second to fourth left interspace. So this is a little bit different. Early diastolic decrescendo, heard best with the patient sitting and leaning forward. Interestingly, isometric exercises will increase systemic vascular resistance and increase the murmur. So think about that. So basically what that is saying is if you, just what we said with exertional dyspnea, if you do an isometric exercise, make your patient do an isometric exercise, you're increasing the systemic vascular resistance. So basically you're increasing pressure outside of the heart. More blood will push back through that valve into the heart as the pressure in the system builds and the pressure in the heart or in the pump drops. Those relative pressures, the further apart they are, the more blood will go backflow through the aortic valve. A high arterial pressure with a quick drop in pressure during diastole may also be something you'll find on the physical exam. Labs and studies, a chest x-ray may show left ventricular hypertrophy. An ECG will show left ventricular hypertrophy. Same thing. You're just trying to get more blood out, so that left ventricle just gets bigger and bigger, trying to push more blood out. An echo with a Doppler is diagnostic. Again, you can just watch that blood flow, and you can measure all the pressures and things that you need using that. And then a cardiac cath will get you even more information, putting the catheter right there into that valve. Blood pressure control, blood pressure control, focusing on decreasing afterload. So again, that makes sense. If you can drop the arterial pressures, the systemic arterial pressures for aortic regurgitation, just the opposite of stenosis, you'll get less pushback into the heart through that valve. You get less backflow if you can drop the vascular, if you can dilate the arteries for, in this case. And then you may need a valve replacement if that has become so insufficient that it's just not functioning. All right. So before we get into the answers to our questions, real quick, our study tip for today, which I've been covering in shows throughout all of season 2, our study tip for today is just going to be to, once again, get over onto the website, check it out, sign up for the email list. I've been putting out a ton, and I'm going to continue to put out tons of study tips, things that will help you learn better, things that will help you focus better, things that will help you to build your confidence. All of this stuff is what I'm been covering specifically in the email list, less here on the podcast. I don't know. We'll see how that goes moving forward, but definitely head over there and check it out, either on your computer, on your phone, or if you text 33444, if you text text to that number, PA exam, all one word, you will get right onto that list and get picked up on that. So you'll start getting all that stuff immediately. And like I said, I think you will be very, very pleased that you do based on the feedback I've been getting from those people who are on that list as of today. Answers to our questions. Were you paying attention? Did you hear them as we went through? Where are the sounds from the pulmonary valve typically heard best? Where are the sounds from the pulmonary valve typically heard best? The left sternal border in the second left intercostal space. A little redundant. Left sternal border in the second left intercostal space. Is aortic stenosis more common in men or in women? More common in men or women? Men, 3-1. And lastly, define paroxysmal nocturnal dyspnea. These are attacks of severe shortness of breath and coughing that generally occur at night, usually awakening the person from sleep. And then also, I don't have this written in my notes, but it's also that you don't recover right away. It's not like orthopnea where if you sit up, you start to feel better. In this case, it usually takes a little bit longer than that. The attack lasts a little bit longer, doesn't clear immediately upon waking. So that's going to wrap us up for today. I am going to spend the next, hopefully only 5 or 10 minutes trying to find where the wave files are for the music for the show, since it's been so long since I've recorded it. I'm going to have to go back and plug all that in, but I wanted to jump right in and get started and record it and make sure that this show got out there. I'm super excited to be back. I'm very excited to be behind the microphone. I wouldn't even mention at the beginning, I am in a new office in my house. My kids are getting older. They want to separate rooms. I used to have one of the bedrooms as my office. I have been kicked out of that room. So this is the first time I am officially recording in my new office. So far, it seems I've worked out pretty well. We'll see moving forward. But I want to thank you so much for tuning in, for listening, for being part of the community. And then, like I said, I strongly encourage you to become a bigger part of the community and go sign up for the email list. And I can't wait to share more with you over there. All right. So until next time, next time we are going to pick up on where we left off here on Murmurs. We are going to maybe get through the rest of them. We'll see how much time we have and how things go. So anyway, take care. Let me know if you have your exam coming up. A few of you have. Good luck to you guys. I look so forward to hearing how you do, whether you passed, whether you failed. There's lessons in all of that for everyone. So please let me know. Good luck to anybody taking their test this week, though. And I'll talk to you soon. Take care.